Bueno, buenas tardes. Bienvenidos para una nueva sesión plenaria con dos excelentes presentaciones e invitados. Así que vamos a dar comienzo con la primera presentación. Para ello hemos invitado a una persona que le ha tomado mucho cariño a Colombia. Es profesor de la Universidad de Miami, como es el doctor Dushyantha Jayaweera. Pero por favor, que nadie lo llame doctor Dushyantha Jayaweera, sino doctor J, que es la forma en que el universo lo llama y es la forma en que nosotros también lo llamamos. El doctor Jayaweera, es profesor de medicina en la Facultad de Medicina Miller University of Miami, en la Universidad de Miami, licenciado en medicina en Sri Lanka, y de ahí viene su apellido, y ha realizado estudios de posgrado en el Reino Unido y en Estados Unidos. Investigador y especialista en VIH durante los últimos 25 años, comenzó su carrera en el campo del VIH antes de la llegada de la terapia antirretroviral altamente activa, antes de la terapia HART, y ha desempeñado un papel activo en muchos ensayos clínicos con terapia antirretroviral altamente efectiva. En la actualidad es el investigador principal de contacto del estudio de la vacuna COVID-19 de Janssen, patrocinado por el Instituto Nacional de Salud, y del estudio de la vacuna antigripal de RNA mensajero de Pfizer, del estudio APTIS-6, patrocinado también por el Instituto Nacional de Estados Unidos, y de otros múltiples estudios patrocinados por la industria en materia de VIH, hepatitis C y COVID-19. Tengo que mencionar que también fue mi mentor cuando yo estuve en la Universidad de Miami, ya no quiero decir cuántos años atrás, pero sí algún tiempo atrás, y desde entonces pues nos ha unido una amistad que permanece hasta el día de hoy. Así que, Jay, thank you very much for being with us again. We made it! We made it! So come on and please proceed.
Thank you, Ernesto. Thank you. Thank you so much, Ernesto. It's been wonderful to be here in Bogota. It's like a second home. I have been to Bogota many times. I want to apologize. I should know Spanish, but I speak in English. As a compromise, I teach my daughters to be fluent in Spanish so that at least what I couldn't do, my kids would do, so that I can be proud of them. So I want to thank Ernesto for arranging this meeting and the Colombian Injectables conference organizing committee for inviting me. It's always a pleasure to be in Bogota. Now, and of course, among all the friends. So today my talk is going to be HIV and antiretrovirals. Where were we before? Where are we now? Where are we going in the future? So it's a kind of a broad topic in 30 minutes. That's impossible. But I'll try. So if I miss something, you know that I tried. So the past. So it's funny because a couple of days ago, one of the postgraduate graduate students were writing a thesis on discrimination on HIV in 1981 by Ronald Reagan. And I was going through the interview, the first time that Ronald Reagan had a press conference on HIV, and the reporter asked about HIV, and he started laughing. And the press corps also started laughing. And the guy who asked the question, who was not from New York Times, asked, what is there to laugh? We just said that 6 people died of a disease that we don't know what happened. And is there something funny about this? And it was really reported. But it took a long time for them to accept that sexually transmitted diseases is not a curse from somebody, but it is just a behavioral, unfortunate incident that doesn't define anybody. And some people have only one husband and they get infected, and there's nothing you can do about it. There's nothing you can do about it. It's not a judgment of the morality of the woman, but it's the social situations that happen in life. So that was the history, and that's what we are. And unfortunately, we should not go backwards. United States is going backwards. At least I hope Colombia is going forward. So you can see on this slide that the development of, we developed AZT in 1987. I was in United Kingdom in 1991 running the Concord study for Birmingham, running the AZT. And you can see the evolution. And there was a kind of a smart-ass company called Gilead who started in 1992 HIV drugs. And we thought that they were joking to see suddenly they become the powerhouse of HIV drug development. So that's how the world changed. So you see the list of drugs that were developed. You can see that we buried some of them. Most of them are buried now because, you know, oops, sorry. I'm going the wrong way. Wait a minute. Okay, so most of these drugs were sort of, you know, laid to past. But did I? Yeah, I think. I think we liked it. I think I done. This one is the one. Yes. Okay. The school pay, right? Okay. Okay, that's good. Okay. Okay. Okay, so the present. So the present is coming. So one of the things, this is the thing that I'd always tell my medical students. A good physician treats the disease, but the great physicians treat the patient who has the disease. This is really important. Just remember that. No matter what much you know about medicine, no matter what disease you practice, if you don't know the patient, you don't know how to treat the patient. So all your knowledge is down the tube. So it's very important. And it's really important in HIV because it's a long-term relationship. It's not like treating hepatitis C. You treat for 8 weeks or 12 weeks and done, gone home. Hepatitis C is like getting married. And it's going to be there for a long time. So, and you can see what we have now. We have these integrase inhibitors, Biktarvy, dolutegravir, and NNRTIs like ribavirin and doravirine. You have these protease inhibitors. You know, you see the list. You have nucleosides. You have attachment inhibitors. You have, CCR5 blockers. And you have monoclonal antibodies. So you have the whole list. The question is, which one to use? Who do you treat with what regimen? And how do you pick and how do you move forward? So there are guidelines. The DHHS gives the guidelines. For example, the DHHS tells you one thing, IAS tells something. Basically, it's very tilted towards integrase inhibitors. So basically it's saying that use Biktarvy or dolutegravir-based regimen with mismatch of nucleosides. And the IAS says something similar. So basically, we are going forward with the most effective drugs that are available. And we all know that the integrase inhibitors are the most powerful. And so therefore, that is it. And I know that this morning, Ernesto was telling me that there was a discussion about 2 drugs versus 3 drugs. The 3 drugs argument came based on the strength, the potency of the agents that are available at that time. So if you take somebody with, say, 100,000 or 500,000 viral load, which is 5.5 log or 5 log viral load, each drug has a potency of dropping the viral load by a certain logs. For example, integrases will drop by about 2.5 logs. And the NNRTIs may drop about 1.8, and the nukes may drop about 1.2, some little less. But you get the picture. So if you put 2 powerful drugs, you can drop 5 log drops with 2 drugs, and you've done the job. So it's really important to understand so whether it's 2 drugs or 3 drugs, you know that how to mix and match. So the question is, now if you're using a first-line drug, you'd use a boosted PI, or what is the rule for boosted PI? So one thing is that if you're doing a test and treat, like rapid start, boosted PIs has some edge over integrase inhibitors because the barrier to resistance is slightly better. Although integrases have very good barrier to resistance, boosted PIs have slightly higher barrier to resistance. That has been shown in some studies. And of course, if there's a high degree of poor adherence, then boosted PI may have a product. But of course, then you have to look at the cons about it, challenges, drug-drug interaction, intolerance. You can see that all the complications with the boosted PIs. Now, if you take the NNRTIs versus integrases, well, the NNRTIs, the possible role is that it's never going to be in front of integrase inhibitors. It is like, oh my goodness, who is that? That's my daughter from Miami, sorry. The NNRTIs can't beat integrases because integrases are much more powerful. But if you can't tolerate, or if you have a weight gain with integrases, then you can switch to an NNRTI. Now, I'm speaking about weight gain tomorrow. I would strongly urge you to come and listen because there are a lot of nuances about weight gain, which is something that Ernesto was asking me to speak. And it's really interesting when you analyze the weight gain in HIV. But the challenges of NNRTIs are the low barrier to resistance. If you miss a couple of doses, you develop resistance. The neuropsychiatric problems with efavirenz, then with say for example, ralpovirin, if the viral load is high, the CD4 is low, it tends to fail. And then you can see that, you have to take with the meals, there are all those restrictions. These are all problems for people taking NNRTIs. The next question we have is Truvada or TAF? So there is a debate as to, is it really, do you need to go with TAF or not? We have a lot of experience with TDF for a greater number of years. We have experience. It's mostly co-formulated, especially in resource-poor setting. Tenofovir is much more available. Lipid decreases, I mean, there's a little advantage over lipids with tenofovir. The weight gain signal, clearly an advantage come up to TAF. And it's available in generic. So, I mean, there are some advantages. But the TAF advantage is that it's superior to tenofovir, especially if you go for 144-week data on the comparative studies. Less bone, in fact, less kidney problems, and smaller tablet, especially when you're doing the protease inhibitor, Simtusa. It has a smaller pill because TAF is very small. So abacavir also has a place. It's co-formulated with dolutegravir. Long history of use and not really nucleated. But then, of course, all the baggage, it comes with the hypersensory reaction and HLB5701 and all the other problems that with abacavir. So let's get down to the injectable Caprovia and ralpovirin. So this is a combination drug that was created for injectable. So it can be used, the indication either replace currently used antiretrovirals oral, or you can, if you're on a stable regimen, you can switch. If you're naive, you can use it, or any condition like that. But of course, if you have suspected resistance to any NNRTIs, you can't take it. So you should be very careful when you're using it that you cannot use if there's NNRTI resistance because ralpovirin is an NNRTI. And the tablets are, you can get injectable, 200 milligram, 300 milligram per ml. And of course, the tablets are 30 and 25 milligrams. And you have to give it in the butt, which creates a pain in the butt, but it becomes funny in English. So this is how the thing is given. So you have to think about the practicality of this. So I'll get to that in a little while after I talk about the injectable. So here is the way to do it. You have to do a sort of oral lead-in. You don't have to always do oral lead-in, but if it's preferred, if the patient is undetectable, if you know the person, then no history of allergies and the patient is doing an integrase inhibitor, you may be able to go without an oral lead-in. And you get, and then you give 1 month oral lead-in, and then after that you give 600 milligrams and 900 milligrams, and after that you can, cut down the dose. So I'm not going to go through all the studies. There are multiple studies to show the effectiveness of these two drugs, and they have worked very well. So there is nothing to argue about the efficacy of these drugs, cabotegravir providing combination, and it works well. So now for Temp Severe. Temp Severe is actually a prodrug. The active drug is called Temp Severe, and it's an attachment inhibitor. This was initially developed by the BMS, Bristol Myers Squibb, and then they decided to give it over, I think it was GSK who took over. And so if you look at the CD4, so the GP120 protein, it attaches to the CD4 receptor and the CCR5 receptor, and you can see that as the thing gets attached at the GP120 binding site, the first Temp Severe breaks down, and Temp Severe comes and blocks the attachment between the binding site of GP120 and the CD4 receptor. So now if you push it a little further, what happens is that the V3 loops join the CCR5. Now the Eleusimap binds to the point where the CCR5 joins the virus. So these are in the D1 to D4 domain. So you can see that how these two drugs affect the binding and therefore decrease the viral load and the viral replication. So if you take first Temp Severe now, the attachment inhibitor, it's only for heavily pretreated patients. So one of the problems with this drug is that we don't have these patients because all the patients are well controlled. And in fact, we didn't do the study because when Bristol Myers approached me, I said, I can't find patients. I mean, I know Luis was working with us at that time. We couldn't find patients, so we said, So my colleague from Yale, Mike Kozal, he was initially at Stanford and went to Yale. He took over. I mean, somehow he managed to wangle it, and then he got a New England Journal paper on this. So he, he's a great scientist. And then the doses are 600 milligrams twice a day. Obviously, you have to insufficient data used in pregnancy, and of course, side effects are nausea, which everybody has. So this is the study that was published by Mike in New England Journal of Medicine 2020. I'm not going to go into details, but I'll get to the next slide, which shows in a heavily pretreated people, people who had no other options, using first Temp Severe, you could bump up at least get the viral load undetectable in 60% of the people, compared to the arm that was given as expanded access. So I'll go back one slide. So there was one arm which was randomized if the patient had failing antiretrovirals, had viral load more than 400, multicaral resistance, but had at least one agent active. So that group got randomized into the main arm, but there was a non-randomized arm which they are comparing. Non-randomized arm, which is the real train wreck, even they had 37% undetectable, and the CD4 count bump was 205 and 119. So you can see that there is hope that if ever we get into trouble with antiretrovirals, first Temp Severe would be helpful to rescue people who are failing regimens. Similarly, Eleusimap is a monoclonal antibody, and again, here's heavily pretreated. Dosing is 2,000 milligrams IV and maintenance of 800 milligrams every 2 weeks. And then the common adverse events are diarrhea and things like that. So the problem with Eleusimap is that it's an IV drug. So it's not easy. I mean, just imagine the practicality of it. Even in the United States, this is not easy. This is not easy to get somebody in, give an IV, and the clinics are not set up to that, except in an ID clinic where they are you giving IV antibiotics. So something like that, this is not easy. Unless we have a home infusion service, then go and give this. But again, nobody will set up a home infusion service because the number of patients you have to use this drug is not that many. So here is a study that showed the use of it, and you could get at least 60% of the patients less than 50, 43% less than 50 copies, 50% less than 50 copies, pretty effective. And those are the drugs that are currently approved, and now how you to mix and match. So now we go to the future. Now, Islatrovia is one of the drugs that Merck developed, which is like it's a nucleoside analog inhibitor with translational inhibitor. So basically, what it does is that it not only, now if you look at the nucleoside analogs, they just combine and then they just, they just mimic a nucleoside and just creates a mismatch, and the form in the chain does not get completed. This actually joins to the end and does the chain termination. So not only that it acts as a nucleoside analog, but also it acts as a chain terminator. So and causes the chain termination. So it has a double act. So there are multiple other great attributes to Islatrovia. So Islatrovia, it's a high binding capacity. So if you compete, say, other nucleosides than Islatrovia had a much higher binding capacity than the other nucleosides. Half-life is tremendously long, 80 to 214 hours, so it's very long. It slowly metabolized. One of the nice things about Islatrovia is that Islatrovia will become triphosphate, get attached, and then get disattached, and go out of the cell and go into another cell. So in that way, Islatrovia has a tremendous ability to recycle itself so that it can be reused by the body. I don't think the virus likes it, but we like it. Even though there are resistant mutations, it doesn't has any problems. So when Islatrovia was combined with doravirine, compared with standard doravirine 3TC with TDF, we found that it has a very good effectiveness, and also there was weight gain was a problem, but not that bad. So again, I'm going to go back one more time. You see that there 37% of the Islatrovia arm had a more than 5% gain, and doravirine arm had 22.6%. So these are significant numbers, yet you have to remember. So now Islatrovia with MK8507, there's a new NNRTI that Merck is developing. They're working on that. It has a similar resistant profile, and also it's been used for pre-exposure prophylaxis. But the tragedy is that the drug is on hold because it causes leukopenia. So now this is really important to remember. When COVID came, you remember the crystal structure of COVID was released on January 10th by the Chinese. And, we all were using these drug development platforms. We have this artificial intelligence using like algorithms, like you put the crystal structure and tell the computer to spit out what drugs in their library would work against COVID. So we had like 2,000 drugs that would work against COVID. None of them worked. None of them worked. It's embarrassing to say none of them worked. We thought hydroxychloroquine would work. It didn't work. We thought ivermectin would work. That didn't work. So actually right now I'm doing still a study with ivermectin. We don't know where that will go, but all the studies are showing none of these things work. So same thing with Islatrovia. Now we are hoping that this leukopenia thing will be settled, and we'll see whether it works out. One thing I know that for drug development, the pharmaceutical companies have a much better scientists in drug development than NIH or anywhere, because they have skin in the game. If they screw up, they know that they are out of the job. NIH, they get another job. So lenacapavir is a capsid inhibitor. Now, as you know, in the HIV virus, there's a capsid containing, there's a cover in the outside of the virus. So what happens is that the capsid inhibitors affect with the capsid disassembly, because capsid has to disassemble and then the RNA of the virus to make a DNA copy, that gets disrupted. And then with the end of the cycle, when the capsid is formed, that also disrupted. So lenacapavir has multiple points of attack where it blocks the viral replication, and it's pretty effective. It's pretty effective. I was just telling Ernesto before we started, I was doing a study which got stopped because even this drug is on hold because it has, it comes in a borate silicon crystal vial, and the glass was breaking off from the vial. Gilead had nothing, couldn't do anything. FDA didn't know about it. So, I mean, it's not a big deal. I mean, it's in the public domain, and they're working on it to come back. And we are very optimistic that this drug will come back. I'm sure, since this is a scientific meeting, I'm sure my colleague Luis can enlighten us, because it's not a promotional, so Luis can talk, you know, and tell us, you know, whether things that I don't know. But I am very optimistic that this will come back, and this stuff works, especially if you combine with broadly neutralizing antibodies, it works. So lenacapavir is the first of capsid inhibitors, both oral subcutaneous, and half-life is about 12 days, accumulates, can give it every 6 months. You can't ask for anything more than that, you know. So here's the Capella study. We are looking at the phase 2, phase 3 patients with viral load more than 400, resist to more than 2 agents, so these are experienced people, randomized to either lenacapavir optimized background or either sub-Q. You go in with sub-Q every 6 months with optimized background, and yeah, we have a randomized arm and a non-randomized arm. So basically, non-randomized arm is the more difficult arm because they don't meet the criteria. And if you just look at the success of this one, you can see almost like 90% having undetectable viral load. And if you have active drug, if you have 2 active drugs with lenacapavir, 94% will be undetectable. So it's very, very potent drugs, very potent drugs. So, and of course, like any HIV drug, the virus develop resistance. No matter what you do, virus develop resistance. So this has developed resistance, and the side effects is the injection site reaction, because unlike the other drugs which are given intramuscularly, this is given subcutaneously. So most of the drugs that are given subcutaneous depot injections causes a subcutaneous reaction. It's normal. So, and of course, you know, but nobody really discontinued this. And you can see that the CD4 rise is pretty good. And if you look at Calibrate study, which is a naive study, in the naive study, it's very simple. Gilead was trying for the first time, lenacapavir with either TAF or breaking bictegravir into Biktarvy and TAF, and testing each one separately in this study, compared with the both Biktarvy, TAF, and FTC, and of course lenacapavir and FTC. So what we find is that on the left-hand side is the capilla. So I don't want you to get this mixed up. On the left-hand side is capilla, right-hand side is the calibrate. In the capilla, where the heavily pretreated ones, they have the 94% success. On the right-hand side, in the calibrate, you can see that all the things did well. I mean, the Biktarvy also did well, but it just gives you an other option to use. So if you think that the weight gain will be a problem or things like that, there is an opportunity in the future that we may be able to tease out these things. So let's talk about the future. I think I have another about 10 minutes. This is the future. This is the future, right? So as you can see, the future looks very bright, very bright. I'm surprised that so many people are investing in this. I think we are doing it because there is a great need, because it is true that, that we have highly effective drugs. But we know we are dealing with a virus. We know that sooner or later some of these things will fall out and you can start developing drug resistance. So I'm not going to go into details, but if you take the entry inhibition, there is another drug which is coming on inhibitors. There is the Islatrovia, but Merck is developing two other drugs like the NRTTIs. And then you have the NNRTI, which is non-nuke, which is elsalbutamide, and then the cabotegravir. And you can see the whole list of drugs that are there that been in the pipelines. These are very early. There's a huge difference between a tissue culture, a rat who is humanized, and a non-human primate, and us. There's a huge difference. It's only like 10% of the drugs that are worked through from a mouse model to a non-human primate to a human actually comes to, I mean, just imagine, Islatrovia and Caprovia, two giant pharmaceutical companies got shot on the foot by this. So what are the chances of these coming to market? But they're there, so they're working on it. So here's an interesting one about the anti-CD4 antibodies called UB41. This was run on, again, the people who were at, this is on, this is a very small study, looking at people who were on Proteus or NNRTIs, giving this with the optimized background, and they are getting almost 94% undetectable. But this is a very small study. So I'm not going to hold my breath on this to come into market, but just to show that these drugs will work. There are antibodies. So there was an interesting review by Mohammed and others, as given the rest of us, targeting CCR5 as a component of HIV therapeutic strategy. So one thing we have to remember is that CCR5 is not a heck of a strong site. The second thing is that you know, they do develop resistance. I mean, they do develop resistance at the CCR5 site, and also they can open up the CXCR for another site. So no matter what you do with CCR5s, you need antivirals. You need antivirals. You can't do it alone just by blocking the CCR5 receptor. So then Abbott came up with another interesting drug, long-acting fusion inhibitor called abovitide. Abovitide is intravenous. It works, but it's intravenous. You need 3 loading doses and then every week. Along with, so this study was done with lopinavir because all companies do incestual drug deals. So Abbott did this drug, and I don't know where this will go, but I personally think that if this works, they should talk to Gilead or they should talk to Merck and work together, because that's the only way that you can move this forward. So broadly neutralizing antibodies, that's something that is going to work. Now I want to go back one slide, couple of slides. This here, if you look at the list of broadly neutralizing antibodies, they are really the drugs that are coming to work. And they are, if you combine them with one of these long-acting, like think either Islatrovia or the other drugs that are coming out, this would be a game changer. So, okay, okay, I want to go back. Okay, so broadly neutralizing antibodies. So this also has a problem. The virus developed resistance. So when you use BNAbs, you have to use multiple BNAbs to overcome the resistance. So if the virus has one antibody, then you have the other antibody. And also there are the antibodies against antibodies. So you have to fight that against. So you have to have these very, very well humanized antibodies which do not against antibodies, and then have multiple antibody combinations to prevent the failure. And I was saying that I can't give you too much information about the study I was doing, but it is good. And in the future is therapeutic HIV vaccines. Again, you know, in addition to all that what I said. But the history of vaccines is pretty bad. I'm sure somebody is speaking on vaccines in this conference. That there's no good track record of vaccines, you know. But it's a good idea. I mean, basically, if you can use vaccines as a therapeutic to kind of, to boost the immune system and also to mitigate the viral replication, that this could be a potential drug that could be on a therapeutic modality that can be used to overcome some of the resistance. And so in summary, the treatment evolution is phenomenal. As I said that when Ernesto asked was, far, I said, sky is the limit. I mean, this keeps moving. And you'll be surprised the number of concept sheets that are happening that will develop new drugs into market. There are so many new concept sheets. Currently, we are going towards a long-acting preparations. Future of Islatrovia, Caprovia is uncertain. There are many other agents in development. Injectables are good, but implementation is a problem. BNABs, I have faith in it. Vaccines may work. And so, ladies and gentlemen, I think it's so important that we keep our eye on the ball and we push our legislatures and our public and work towards getting ultimately HIV cure, which sooner or later we will come. And with that, I want to thank Ernesto and Martinez and the great organization for inviting me and all my colleagues I have met before from Colombia in previous talks. And thank you very much.
Gracias, doctor Jay, por tan linda travesía a través del mundo de los antirretrovirales y de lo que además nos ofrece el futuro. Ernesto olvidó decir que el doctor Jay nos ha acompañado en las 5 versiones de ACINVIR. Es un punto muy importante, Ernesto, que olvidaste. ¿Sí?